Hey there. Once again, we're going to continue our conversation on heart block dysrhythmias. We just discussed the first degree AV block. Now we're going to continue to second degree AV block. Now the variation of this is that there are two types of second degree, and we're going to begin with the first one called Wenckeback. This dysrhythmia has very particular characteristics that are help you to easily identify this from the other ones. So let's take a look at it. Now, previously we saw that first degree AV blocks are mainly composed of delay in the signal from the AV, from the SA to the AV. Now we're going to look at second degree, which means that the impulses, first they were being delayed. Now the variation in this is that we're going to be having a blocked or conducted, non-conducted impulses. What does this mean? It means that the impulse occurs too soon after the preceding impulse, causing a period when there is no impulses that can occur into the ventricles. So every time there's an impulse from the SA node down to the AV node, if it cannot pass through the AV node in the proper time, you're going to have a further delay or a blockage of that impulse where the ventricles will not be depolarized, and therefore you will see no QRS. You will see the P wave being detected in the EKG because the SA node fired, the EKG detected that impulse, but did not make it through the AV node to the ventricles where it would reflect the QRS. So this is what we're going to see now in second degree AV blocks, or we like to call it Wenckeback dysrhythmia. This dysrhythmia is called Wenckeback because it was named after the physician that discovered it. Dr. Frederick Wenckeback is his name, and he followed up on some work that was previously discovered by another physician, Waldemar Mobitz. So second degree AV blocks are sometimes referred to as Mobitz 1 or Wenckeback because of those two physicians. So with that being said, what are the main characteristics? What are we looking at for? Remember I said there's going to be missing or blocked impulses, okay? We should say non-conducted impulses, not missing, just non-blocked, non-conducted. They were blocked at the AV node. So if you look on your textbook on figure 8.4, one of the main characteristics also is that there is a progressive increase in the PR interval, where before in first degree, they were constant. The PR interval was greater than 0.20, but was constant, would just stay longer and longer, right? In this one, you're going to see that the defining characteristic is that one, the PR interval is going to continue to get bigger and bigger and bigger until there's a blocked or non-conducted impulse. So you're going to see a lonely P wave. Okay, so let's look at figure 8.4 so that we can have a better idea of what I'm talking about. So I'm sharing with you a screen now. This is an example of a variety of impulses. Okay, so here you see, right? You can see that PR interval is way beyond, right? Should be no more than 5 little squares. Here we have almost 10 little squares, which is twice as long. So there's definitely a right delay or prolonged. Okay, this is your R followed by your T wave. Okay, and then the next QRS, this is a P wave. The next beat here is a missing QRS T or P wave rather, and then this is another missing beat. Okay, so this is impulse, should have been here, the ventricles, but it was blocked. So you have your P, but no R. Therefore, the impulse was blocked. You see the PR interval on this next one. It's still prolonged. You have 1, 2, 3, 4, 5, 6 little squares, which is 0.24 beyond the PR interval parameters. So it is longer, okay? And then you have blocked here, okay? Blocked, prolonged, and so on. Again, one of the characteristics of this second degree Wenckeback, it's that the impulses are, or the PR interval gets longer and longer. Okay, and then you have a missing non-conducted impulse. So PR gets longer and then non-conducted impulse. So looking at the criteria for classification for this dysrhythmia, you'll notice that the P and the P are regular. So the P's will always be there and regular because the SA node is firing. They're being detected by the EKG machine. So therefore you see a P wave. So you see P wave should be irregular. However, you will see an irregularity in the R waves, mainly because there will be blocked impulses. You will see R, R, and then a missing, right? It may be R, 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 and there may be a missing impulse. So that makes it an irregular. So for this rhythm, again, is irregular. The rate, you have to calculate the atrial rate and the ventricular rates. In this case, because they might be missing QRSs, missing or not conducted impulses, you notice that the ventricular rate will be less than your atrial rate. So you count your P waves in a 6-second strip because this is irregular. You count the P waves, you multiply times 10, and that'll give you your rate. Same thing for the R waves. So you notice the difference, right? The ventricular rate is usually slower than the atrial rate. Now the P wave morphology, the shape of the P waves may be completely normal in size and upright. There should be no negative deflections. There is a P wave for every QRS, but there are going to be extra P waves recorded on the EKG. That's another characteristic. The PR interval, as we said, varies from one measurement to the next. The PR interval becomes progressively longer, and then you have the non-conducted impulse. So keep that in mind. The QRS duration and morphology should be completely normal within 0.06 to 0.10. All right, so this is the criteria for a second degree AV block, Wenckeback, or we want to call it second degree Mobitz type 1. It's another name, but I think Wenckeback would be easier. That way we can separate it. So again, doing a tip here. In second degree AV blocks, has a cyclical or progressively longer PR interval until the QRS is blocked. Then the cycle resets and begins again. So should the patient have any symptoms at this time, it depends on the ventricular rate. If it begins to go below 40, decreasing cardiac output, the patient may start to feel the symptoms of low cardiac output, dizziness, confusion, shortness of breath, and so on. So this is what we'll need to look at. At this point, with this kind of arrhythmia, the doctor should implement some type of treatment, including medications what are called antiarrhythmics that will help the cardiac cells be more excitable or correct this abnormal rhythm. So why do we have to keep an eye on it? Because it will progress to a worsening rhythm, which is something that we don't want. Let's see if we can take a look at some another rhythm. Let's see with this one. This is So again, if you evaluate this rhythm here, you see that the P to R is about the same. There is no really significant change. Okay. However, you look at this one, you see the P wave here, P wave, and the duration is definitely longer. In this case, we have 5, we have about 7 little squares, which equals about 0.28. And this one, you see, we have 1, 2, 3, 4, 5, 6, 7. This one is actually consistently, the PR interval is consistent. So this would be a first degree AV block. This is not a second degree. Let's try to look for another one here. See if we can find another. Oh, let me see here. I see this one here. I think this is it. Okay, let's look at this one right here. The PR interval here looks pretty normal. It's about 1, 2, 3, maybe 4 little squares, 0.16. Then if you look at here, P to the R, this is a little bit longer, 1, 2, 3, 4, 5, 6. So this is already beyond the parameters, 0.24. Look at the next one. This goes 1, 2, 3, 4, 5, 6, 7, 8. That's 0.32, which is progressively longer. So from normal to longer and longer. This is what we call a second degree AV block Wenckeback. Okay, second degree AV block Wenckeback, or you can call it second degree Mobitz type 1. Second degree Mobitz type 1. Remember, it was named after those physicians. So Mobitz type 1 or Wenckeback. And that's what happens after this one. There is a missing or non-conducted beat right here. You have your T, P wave, and your QRS should be about right here, but it's missing. It's gone. So this is what makes the rhythm irregular. So this is, again, second degree type 1 Mobitz or second degree Wenckeback. So longer, 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 and then drops. Okay. And this other one, you can see that the PR interval is consistent. Okay, consistent. Now, is it within normal parameters? You have 1, 2, 3, 4, 5. This is a completely normal. You have 1, 2, 3, 4, 5, 6. The rate is regular. The P waves look pretty much the same. PR interval is the same. QRS is within the parameters. So this is a normal sinus rhythm. And here we have your second degree type 1 Mobitz or second degree Wenckeback, characterized by the progressively longer PR interval, and then a drop, non-conducted impulse. This makes it a second degree type 1 Wenckeback. Okay, before we move on to the next arrhythmia, please make sure you complete the checkpoint questions LO 8.3, and we'll be going on to the next one, which is again another type of second degree block. So hang in there.